Good morning, everyone. I am Dr. Gargi Saran, Senior Lecturer from the Department of Oral Medicine and Radiology, and today my lecture is on TMJ imaging. Now, TMJ is a gangliomo-diarthrodial joint that is freely mobile with superior and inferior joint spaces separated by an articular disc. This joint can transverse in any direction that can be superiorly, anteriorly, inferiorly, medially, and sideways also. So that's why it is named as ganglio-diarthrodial joint. It is gangliomo-diarthrodial joint that is freely mobile. It can move in all four directions. Now, we are going to discuss about the TMJ imaging. What are the imaging modalities that are used nowadays to visualize the TMJ? Generally, TMJ has components that are visualized in an OPG or in a conventional radiography. We will see the head of the condyle, the articular eminence, the bony structures, the joint spaces, and other supporting ligaments that support the TMJ to be held in its position. So, the conventional OPG machine orients the X-ray beam obliquely through the condyle. Limited view of fossa and condyle is seen in conventional OPG. Dental panoramic ray tomograph. So, this is dental OPG we are talking about. So, what are the indications when we advise such an OPG to the patients? TMJ dysfunction syndrome, disease within the joint, pathology of condylar heads, fracture of condylar head or neck, condylar hypo or hyperplasia. Advanced high panoramic radiography is seen when we change this modality into more digital form and we inject the contrast media in the joints. Then we go for advanced panoramic radiography. And for digital radiography, option is also available to only visualize the open and the closed mouth TMJ views, in which we can see how the TMJ transfers towards while opening the mouth from its space anteriorly to normal joint space and comes back to its position. So it's a very interesting thought that we can take records of such TMJ joints that translates from its position to maximum mouth opening. So we can see the transition of the condyle head that has to be transversed anteriorly during the mouth opening. So in closed mouth, we can visualize the condylar head, and in open mouth also, we can visualize the condylar head. Now, condylar long axis with respect to the mid-sagittal plane can also be viewed with submento vertex view. In this, we can view in the mid-sagittal plane, both the condylar heads can be visualized by submento vertex view. We ask the patient to rotate his head to an angle permitting the alignment of the image slices perpendicular to the condylar long axis. So if we ask the patient to stretch his neck posteriorly and then we shoot the radiograph from here, so we'll always get the condylar heads from the mid-sagittal axis or the position. Now, as we are only dealing with TMJ imaging, I'm going to show you a few radiographs that will help you to analyze what we are talking about. So panoramic images that are revealed, over here we can see the condylar hyperplasia, that is the overgrowth of condyle. Over here we can very well appreciate that condylar head is curved a little bit and has grown outrageously. But over here we cannot see. same condylar hyperplasia. It is only observed in the right side. And destruction of the condyle by malignant tumor. In the second image, we are seeing on the left side that there is severe destruction of the condylar head by a malignant tumor, and these black arrows are signifying towards that malignant tumor. And this OPG reveals that condylar head is compromised by this malignant tumor. Then in this OPG, we can see again the condylar hyperplasia resulting in the asymmetry of the jaw. Supposingly, over here we can see the enlarged condylar head with extra growth of condyle over here, and over here there is shortening. And over here we can very well appreciate that this side is asymmetrical or not matching towards the left side. Similarly, in posterior anterior view of the skull, we can see the asymmetry on the face. This is a panoramic image revealing the hypoplasia of the condyle. In this case, there is shortening of condyle and the coronoid process. So over here we can see there is minimum involvement of mandibular ramus, and over here the condyle and coronoid process are not developed fully. So we can appreciate very well the hypoplasia of the condyle and coronoid process. This panoramic image shows juvenile arthrosis. Now, juvenile arthrosis has been taught you before also. In this, especially condyle appears as a toadstool appearance, that a posteriorly inclined appearance. Over here we can see as a frog is sitting in a toadstool appearance. So it's a stage where toad transforms itself to a frog. So in this, as if we can see, this is a toadstool appearance over here. So the condylar necks are absent, and the coronoid is also not appealing, very appealing over here we can see, but we can see the flattening of the condyle on both the sides. So this is very well appreciated in this OPG. Now, in our day-to-day practice, what do we do for TMJ imaging? First, we start from conventional therapy. Conventional radiographs. After that, we will do the therapy. So from conventional radiographs, we start with we utilize a normal X-ray machine in this, and we take the radiographs. So transcranial view. In this, what is the indication? So transcranial view means that we are viewing cranium from the opposite side, and we have to shoot the radiograph of the interest on the opposite side. So it is indicated in TMJ pain dysfunction syndrome, internal derangement, and the range of movements in joints. So we have to check all these things: internal dearrangement, that is of the disc and the articular surfaces, and the range of movements in the joints. The only movement that mandible is capable of doing is the translatory movement, and it is a very important movement because with the help of that movement, the jaw is able to protrude itself anteriorly, and we are able to chew very swiftly. So the area of joint of interest is seen, that is the lateral aspect of glenoid fossa, the articular eminence, the joint spaces, and the condylar head. So this is the transcranial projection in which the central ray is oriented 25-degree positive. This is the positive angulation, that the X-ray beam is like this. And when we go like this, then it will be the negative angulation. But this is the positive angulation of plus 25-degree angle from the opposite side. Supposingly, if we have to shoot the radiograph of the right side, so we will ask the operator to take the position from the left side and make an angulation of plus 25 degrees. So the area of interest and the central ray is transversed in this position like this, and the central ray is then passed to the area of interest from the opposite side, as I've told you before. An anterior 20 degrees centered over the TMJ of interest. So we will use an extraoral cassette, an extraoral 8x10 film comes, and we use an extraoral cassette to record or to maintain this transcranial view and ask the patient to hold the cassette like this, and then we shoot the radiograph from the opposite side with the area of interest, aiming that the central ray will cross to that mandible too, cross that condylar head too, and the central ray will cross and the image will come of the opposite side of the condyle and its surfaces. Then transcranial projections of the left TMJ joints. So over here we can see this is the articular eminence over here, and this is the joint, the condylar head. We can see very well appreciate, and this is the joint spaces. And over here we can see an open mouth. This one is of closed mouth. Now in open mouth we can very well see the translatory movement that the condyle head has come out of its articular disc, articular surface, and it's more anterior to the articular eminence. It is more anterior to the articular eminence, and in this it is the closed mouth, and in this we can see very well appreciate the translatory movement of the mandible in open mouth as it has come out of its glenoid fossa into the anteriorly into the articular eminence. Anterior to the articular eminence. Then what is the transpharyngeal view? It has also called with the names of intracranial view and McQueen-Dell view. So what are the indications? Again, pain, TMJ pain dysfunction syndrome, osteoarthritis and rheumatoid arthritis, pathology, condylar head and cyst and tumor, and fracture of the head and neck of the condyle. Now, area of joint seen in this particular conventional radiography, that is transpharyngeal, is condylar head and neck and the articular surfaces. Film placement. Again, we should very well verse what is the correct film placement when the patient holds the cassette flat against the patient's ear over here and centered over the TM joint of interest. Whichever side we have to shoot, we have to place the whichever the TMJ joint, the area of the interest is, where the patient is having pain symptoms, we will ask the patient to hold the cassette like this against his ear and against the facial skin, parallel to the sagittal plane, ½ inch anterior to the external auditory meatus, and the position of the patient should be parallel to the occlusion plane to the transverse axis of the film, and the soft parts should be in the line with the nasopharynx and the joint. So this is the nasopharynx area and this is the joint. So we will ask the patient to hold the cassette like this. Then in this we will central ray is oriented superiorly 5 to 10 degrees. Over we will take the angulation of 5 to 10 degrees posteriorly approximately. In the coronal section we can see that the angulation, the area of interest should be focused more with superiorly to 5 to 10 degrees. We will keep the tube head of the X-ray unit, and then we'll shoot the radiograph from the opposite side. So in this, we will ask the patient to open his mouth to the maximum mouth opening he can open, and then we will shoot the radiograph. And after taking the radiograph, we can have these radiographic features that are more prominent in this view are the condylar head. Very well we can appreciate over here. We can also see styloid process, the strato of the soft palate, the pterygopalatine fossa, the pterygoid plates, the coronoid process, and the hard palate. So these, and we can very well see the Brammel's area of the mandible. We can very well see the Antigonian lodge over here. Very well we can appreciate that, and we can very well see the head of the condyle and the neck of the condyle. So, and if it maximum mouth opening is there, so we can see is the interarticular disc and the articular eminence are in the correct position, and is there any sign or symptom of the patient associated with all these structures. Then transorbital or Zimmer projection. In this, indication is trauma or in cases of fractures. So the area of joint seen is anterior view of the TMJ, medial displacement of the fractured condyle or fracture of the neck of the condyle. So the point of entry may be taken from the pupil of the same eye, asking the patient to look straight ahead and the medial canthus of the same eye. So we'll focus on the central ray that will come from the pupil of his eye. In this, disadvantage is this: if the patient cannot open wide, areas of the articular joint surfaces will be obscured because of the mutual superimposition of many structures that are present over here. So there are many maxillary sinus and different nasal bridge, and everything is over here. So nasopharynx, all the parts of the nasopharynx. So superimposition of soft tissues will be more. So we will ask the patient to open the mouth properly. If he can't open the mouth, this view can be compromised. So over here we can see the X-ray bin is centered towards the pupil, and the patient is asked to hold the cassette from the back side. And after taking this view, we can very well appreciate the condylar head below the articular eminence and the neck of the condyle to see whether there is a fracture on the neck of the condyle. Then reverse Towns. This is also a conventional radiography in which we see the articular surfaces of condyle with disease or within the joint, fracture of the condyle head and neck, intracapsular fractures if there is intracapsular fracture in, and the condylar hypo or hyperplasia. So the areas of joint seen over here are posterior view of both condylar head and neck. Then sagittal plane vertical to and perpendicular to the films. So now how will we shoot this radiograph? The only forehead should touch the film and the mouth should be wide open like this. And the angle should be of negative 30 degrees to the film. The central ray is directed mid-sagittal plane at the level of the mandible and perpendicular to the film. So over here we can see this is the cassette, and the patient's forehead and nose, tip of the nose is touching the cassette, and the position of the X-ray beam is 30 degree angulated from posteriorly. So after this, if we have taken the radiograph, this type of image comes. And in this, we can very well appreciate, in this reverse Towns view, we can very well appreciate this is the neck of the condyle and this is the head of the condyle. And in both sides, we can very well appreciate the condyle on the left side also. But the right side is a little bit compromised, but we can see on the left side better. So after conventional radiography, we have to find out the fractures, hypo or hyperplasia, any pain associated with TMJ, we can go for conventional radiography. Now ultrasonography also plays a role in imaging modality, that is newer imaging modalities we can use in TMJ patients. Ultrasonography was described to be an alternative method in imaging of TMJ by Stefan et al. In 1992. High-resolution ultrasonography was used to show satisfying results in further studies. So now high-resolution ultrasonography was also been helpful. So what are the advantages of ultrasonography? It is non-invasive and inexpensive. This displacement and joint diffusion can appreciate it. What are the disadvantages? Scarce accessibility of the medial part of the TMJ structures. That is, there is very little visualization of the medial part of the TMJ joint structures. Need of the trained and calibrated operators is also advised, because it's a very tedious thing to look where the problem patient is complaining of the problem and to work the transducer according to that. And then if the images are captured, then a trained operator is required to capture such images and then keep its record. So this is the transducer and the consequent visualization of the temporomandibular joint. A horizontal positioning transverse image of TMJ will be there, and a vertical positioning, that is the coronal sagittal image of the TMJ, depending on the angulation of transducer. So this is the medial side, this is the posterior, and this is the anterior, and this is the skin, and over here we can see the condyle, over here the masseter muscle, and over here the coronoid process. So a horizontal positioning is advised to take the transducer and view the images. Then TMJ arthrography. It was discovered by Norgard in 1940, and in this is more like invasive procedure, because in this we have to inject the contrast media and then view through X-ray source the TMJ joint with the contrast media. So indication should be very, if the patient is not, if the TMJ joint is not being visible by other modalities, then we should opt for this modality, because it's an invasive procedure and most of the patients do not agree for this procedure. So the position and function of the disc pain and dysfunction, long standing, if it's long standing and invasive procedure is required, then only we will go for this imaging modality. History of locking is persistent, that the patient does not open the mouth and the joint locks itself, that is without reduction, this displacement without reduction. So it is more persistent in that. So we will go for TMJ arthrography if patient is having very much pain and it's not able to freely move its mobile anteriorly and posteriorly. So we will opt for this TMJ arthrography. If there is perforations of the disc and retrodiscal tissue, if there is some perforations in the disc and the retrodiscal tissue, then we will go for TMJ arthrography. If there is some disturbances in the joint dynamics, so we will go for TMJ arthrography. As I've told you, it's an invasive procedure, and if there is a long-standing persistent problem of TMJ, then we will go for this modality. Then disc displacement, anterior or anteromedial, then we will go for this image modality. Now, to my interest, I just wanted to put this picture that how the TMJ arthrography is being performed or is being done. The examination is performed with the patient in a supine position, lying on the side, with the TMJ of interest facing towards upwards. Supposingly, this is the light source, and the patient is advised to lie down, and then the source is projected from the upward move, upside. So a vertical positioning of the C-arm with the X-ray source under the exam table results in the lateral oblique transcranial projection, as you can see. This is the patient's head and this is the lateral oblique projection of the upper TMJ joint. So mostly it is for therapeutic, that is to delineate the loose bodies in the joint spaces, as a diagnostic aspiration of joint fluids, as the interarticular injections of steroid. Now, what are the contraindications? Infections in the periauricular region, then we should not perform this. Patients allergic to contrast media, first we should check the allergy if the patient is having with the contrast media. Patients with bleeding disorders and on anticoagulant therapy, and other systemic diseases like other systemic diseases like vitamin C deficiency, vitamin D deficiency. So all these parameters should be well taken for records, and then we should perform this invasive procedure further, because it should not cause harm to patients later on, as it is very invasive procedure and requires a, a, a time period of 15 days for healing. So that's the major issue. So we should not push the patient towards this therapy. If it is required, then it should be done. Then computed tomography. After the conventional radiography, we come to the advanced techniques like ultrasonography. Then after ultrasonography, arthrography, and then computed tomography. So computed tomography is three-dimensional shape and internal structure of the osseous components surrounding the soft tissue. Both axial and coronal images are axial and coronal images means the axial plane and the coronal plane is taken in the consideration, and we can view these images. Reformat images in sagittal plane also, and for a diagnostic. So in this we can see all the bony structures of the TMJ, articular eminence, the condylar head, and we can very well appreciate all the bony components of the TMJ joint. So in cases of ankylosis, we can advise CT. In cases of neoplasm bone involvement, we can, because we know in neoplasm we do not know the involvement, till which extent it has involved the body, the ramus, the coronoid process, all these things, and the disc components, intra-articular disc and the articular eminence and the joint spaces. We don't know till which extent it has involved all these structures. So we need a CT to visualize the extent of the lesions in neoplasm. Then comes the complex fractures. In cases of complex compound fracture, that is when there is very much mutilation of the structures inside the joint space, complications like polytetrafluoroethylene or silicone sheet implants, erosions into the middle cranial fossa, sometimes due to the fracture and everything, the surgeons perform surgeries to hold the mandible in its position, and such implants are used. So they are also visualized in CT to see the extent, exactly the depth of the implant where it is kept. Then heterotropic bone growth. So this is image showing the CT. These are the sagittal tomograms and represent a lateral image slice. Over here, we can very well appreciate B represents a medial image slice of the same joint, and C it's a open view showing that when the condyle is opening the mouth, when the condyle is transferring from its joint space, showing the degree of condylar translation during the mandibular mouth opening. This is the CT image of TMJ from a 20-year-old female. This is the healthy joint we can see with good cartilage, thickness over the condylar head, and yellow arrow has a smooth articular eminence. With the green arrow, as we can see, this is the articular eminence. It is smooth and very well it is seen. Over here, we can see the arthritic joint with loss of cartilage, as you can see over here, and there is thickening and flattening of the articular eminence also. So this is the healthy joint space over here on the right side, but on the left side we can see the arthritic joint. So can you make a difference between the healthy and the unhealthy joint bony structures in this patient? Then the panoramic radiograph displaying the duplication of both the condyles. Okay, over here we can see both the condyles, but over here see, if there is a bifid condyle, we can very well appreciate in the coronal section, coronal imaging, that is coronal computed tomography, the appreciation of bifid condyle is seen over here. Such a beautiful bifid condyle is seen from the coronal section. in a CT. Then comes again advanced imaging modality, that is magnetic resonance imaging or MRI. MRI is mostly advised for the patients with joint spaces disturbances in the soft tissue, in the interarticular disc space, and then we advise magnetic resonance imaging in disc dearrangements and when the disc is causing some problem during the translatory movement of the mandible. So tissue with greater water content emit a higher signal, and bilateral duocerfal coils of 0.5 to 2 Tesla improves gives us, these are the units in which we shoot this radiograph in T1 and T2 weighted images. That 0.5 to 2 Tesla improve the image resolution. Then oblique sagittal and oblique coronal scans with T1 and T2 is done. Closed mouth, partially open and fully open positions are shooted. And patient, when the MRI is going on, we ask the patient to open the mouth, then maximal opening, then again closing. So all the translatory movements are recorded in the scan. Images in the sagittal and coronal planes without repositioning in the patient, because the gantry is moving round and round. When we put the patient in the gantry and the images, the whole system of MRI involves all the planes, that is the sagittal, the coronal, the axial, and we are very well able to see all these parameters of the TM joint. T1 weighted images best are seen osseous and discal tissues, and T2 weighted images we can see inflammation and joint effusion. So T1 weighted images we see best osseous and discal tissues. Matlab, we can see all the disc components are interarticular disc components are correct or not. And in T1 weighted images, we can see all the normal soft tissue structures that are present, that are there. But in T2 weighted images, we will see more more hypodense things that the MRI is showing. In the motion of MRI studies, during the opening and closing, the patient open in a series of step distances and using a rapid image acquisition, that is fast scan. When we ask the patient to open and close the mouth and we start taking the scan, that is known as the fast scan in the stepped procedures. So this is the MRI of a normal TMJ joint. And this is a closed view mouth in which we can very well appreciate this is the interarticular disc, this is the articular eminence, and this is the condylar head and neck. And this is the biconcave disc, as very well appreciated, located its posterior band arrow. Over here we can see over the condyle. And over here we can see the osseous components and the disc superior to the condyle. So this is the complete anterior disc displacement. Over here we can see this is the medial section showing this is the interarticular disc that has completely displaced anteriorly, and over here this is the condyle. This disc should be in between these two surfaces, but it has displaced anteriorly. And this is the open mouth. So in open mouth the disc has also appeared more anteriorly, and the patient is not try to open his mouth more, so there is a disc displacement. Okay, so this over here we can see this is the normal disc that is seen, interarticular disc over the condylar head, but over here we can see it is more anterior, not posterior, not on the condylar head, but more anterior to the condylar head. So this is the temporomandibular joint anatomy. We will, this is the articular eminence, as I've told you before. So this is the condylar head. Now this is the synovial membrane over here. This is the interarticular disc that moves with the translatory movement. Okay, this is the external auditory meatus. This is the joint space with superior inferior ligaments. This is the articular eminence. This is the lateral pterygoid muscle that gets inserted with its superior berry and inferior berry to the neck of the condyle and helps the mandible to make movement. Then this is the posterior attachment, superior lamella, loose areolar tissue and connective tissue over here. So this is the middle cranial fossa. This is your superior and inferior joint spaces. This is the superior and this is the inferior joint spaces. This is the articular surfaces. This is your biconcave interarticular disc. This is the medial collateral ligament. This is the medial capsular wall. This is the lateral collateral ligament. This is the lateral capsular wall. And this is the articular eminence. So over here we can very well see the position and the movement of the disc during the jaw opening. So in normal position, the disc is over the head of the condyle, and when we open the mouth slightly, so see the disc has got a little bit flattened, and we completely open the mouth, the disc is a little bit posterior to the head of the condyle. In partially displaced or in partially displaced disc, we can see that the disc is little anterior to the condylar head, and when the patient opens the mouth, there is a click sound because it comes under the impression of the disc, and then when it moves more anteriorly, the disc appears most posteriorly. Then this is the fully displaced. See, the interarticular disc is more anterior, and when the patient opens the mouth, there is locking because patient is not open the mouth, and when it completely opens the mouth, it locks itself over here, and then there is without reduction, and patient is not able to open the mouth, and there is a lot of pain. Now, what are the advantages of CD and MRI in TMJ imaging? Advantages of CT are direct delineation of the bony structures for surgical anatomy, reconstruction in all the planes, some soft tissues lateral to the pterygoid muscle that were not involved in conventional radiography due to superimposition of soft tissues. So we can very well see in CT because we take its views, we can visualize in all planes the joint. The 3D image from any angle we can visualize. What are the disadvantages? High radiation exposure is there, and soft tissues cannot be appreciated more. What is the advantages of MRI? Again, it is appreciated for soft tissue imaging. Soft tissue, especially the disc and its association in the interarticular disc. Then information in short acquisition time. One of the advantages then in small time we can take so much scan. We can take one fast scan and we can evaluate the joint spaces. Then disadvantages is expensive, and some patients are very claustrophobic. They don't want to go into the gantry and all the sound coming from the magnetic resonance imaging. So they don't want to go. So they are most claustrophobic. So that's why one of the disadvantages of MRI. Then bone scintigraphy. Now scintigraphy is a sensitive technique when there is neoplasm and indication of malignancy, and if we want to see the point of origin of the malignancy. So we advise bone scintigraphy, and bone and joint pathology are seen in this. So intravenous injection of tracer doser of radionuclide technetium methylene diphosphonate is injected in the patient, and planar and tomographic images are obtained in all planes. Indication to rule out any tumors and point of origin of the malignancy or condylar hypoplasia, internal rearrangement. So what are the advantages of bone scintigraphy? Bone changes are demonstrated before they are depicted by radiographic exam up to 6 months earlier in neoplasm involvement. Then only we will go for it. Supposing if the patient has history of there is some family history of malignancy, So if the patient is very well versed of this modality and wants to go for a scan and has having some problem in TMJ joint, so he can go for scintigraphy up to 2 weeks earlier in the bone infection, then it can be known to the patient that he has chance of developing a malignancy or not. What is the disadvantage? Lack of specificity. We cannot specifically say where is the origin of the malignant tumor. But if there is, so this dense image comes, hotspots that we call, is very well appreciated over here, and radio-like imaging of a patient with condylar hyperplasia of the TMJ joint. So this is the advanced imaging techniques that you will be dealing more, and you will be dealt with this each imaging modality separately. So now just we are talking about the TMJ imaging. So it is advised if the patient is having history of malignancy, then he can go for this bone scintigraphy. Thank you for patient listening. Have a good day.